Thank you, and thank you for inviting me to present this project. So this project is a collaboration between myself and Dr. Masaudi, Dean Boden Albala, and Dominic Wodards and Vladimir Minin. And so SARS-CoV-2 transmission, we know from multiple studies, is primarily driven by asymptomatic or mild disease that is just not detected over time. So there's a lot of transmission that occurs before a case gets diagnosed. So, and we also know that young adults with age 18 to 30 years are much more likely to have mild infections compared to older adults. And so, taken together, you can imagine a situation where university settings outbreaks can go undetected for a long time before the first case gets diagnosed. And we also know through multiple studies that, university settings tend to be somewhat unique in the sense that not only are social interactions between peers important outside of classes, but because of the sort of the courses and class network, there are specific networks that facilitate transmission in this population. So really what we need is a system needed to monitor changing social interaction patterns over time, and also to monitor the risk of SARS-CoV-2 exposure and infections over time. So the primary aims of this project are to determine, first of all, the prevalence of prior SARS-CoV-2 infection among UCI students at baseline, and then to estimate the risk of acquiring infection over time, and also to describe changes in social interaction patterns over time. And so taken together, these data can serve as parameters to inform the development of epidemiologic models of transmission within university campuses. And also as a side aim, we also want to validate and to evaluate the utility of self-collected non-invasive saliva specimens for SARS-CoV-2 RNA detection in the student population. So the study design is a prospective cohort study involving longitudinal specimen collection at 4 time points, months 0, 3, 6, and 12. So we initially had planned to start out with undergraduate students, but I think given that most likely, we're hearing that most likely graduate students will come back on campus for in-person instruction and laboratory work earlier than undergrads. So we decided to shift the focus and focus on the graduate students living in or near campus with no plans to graduate or relocate during the next 12 months. Our sample size is 500, and we plan on sampling through a summer graduate student registry or a graduate housing registry. So we will randomly sample 500 students, and recruitment will be done through emailing study flyers and telephone follow-up if necessary. We also will be giving $10 cash incentives for per visit for each participant. So data collection will involve online questionnaires via RedCap and focusing on symptom history, exposure history, and social interactions. We'll also collect blood and respiratory specimens at each of the time points. And so that includes self-collected saliva samples as well as nasopharyngeal swabs collected by RN. And again, the goal here is to really determine whether collection of saliva samples and testing saliva samples will give us similar or the same results as with kind of the gold standard, which is the nasopharyngeal swabs. Laboratory testing will involve kind of some of the similar methods as what Dr. Masaudi presented earlier, except we'll also do RT-PCR for SARS-CoV-2 RNA and ELISA for IgM and IgG. And so really we want this project to, the overarching goal is for this project to serve as sort of a foundation for long-term university-based monitoring system. So once this particular project gets established, we hope to seek additional funding to expand to undergraduate students, and also potentially external funding involve to do a multi-campus study in collaboration with other universities. So with that, I'm happy to take any questions.
I have a question. Sanghyuk, great job on the presentation. The question is in terms of the living on campus versus near campus. One, do you determine there are any differences in what you're trying to do? And secondly, how do you define and measure social interaction patterns?
Yeah, so I think the first question regarding on-campus and off-campus, we do, I think there's going to be differences in terms of social interaction, whether you are living in sort of a dormitory situation versus sort of an off-campus apartment. So, and certainly, you know, students who live on campus may have more opportunities for interaction with their peers versus somebody who is living off campus. So that is certainly something that that we'll want to, you know, to look into and to describe. So regarding social interaction patterns, so it turns out there are multiple studies. So currently in sort of infectious disease epidemiology, there's been a lot of development in what's called network modeling. And so this notion that infectious disease transmission doesn't just happen homogeneously in a population, there's a great deal of heterogeneity in sort of networks that are impacted, and then how infection moves from a certain social network to a different social network. So we'll be you know, adapting a lot of from that literature quite a bit. And so there are multiple you know, questionnaires that have been developed to try to capture that data. So we're kind of in the process of looking through all the different questionnaires that we've been that have been used in prior studies, and to try to find one that would work best in our population.
Thank you.
I think the social networking is a great question, and there's some people on campus we might be able to connect you with. Yeah,
and I do know some people who specifically focus on this area, and you know, so yes, but I'd be happy to speak with you, Suzanne.
So Sean Young is one of those people. I don't know if you're already working with him over in emergency medicine.
Yeah, I'm not working with him directly, but I do know him, so I can certainly reach out to him as well.
And just a comment, I don't think you'll need to pay people $10 to sign up for this study.
Yeah.
Given the interest in ongoing testing. I don't remember how frequently you're retesting this group.
Yeah, so it's we'll be retesting. So there'll be 4 longitudinal specimen collection and testing. So we'll be testing them baseline and then 3 follow-up visits.
And the follow-up timing is
once per quarter. So we're going to start this project hopefully next month, and then and the beginning of each quarter subsequently after that.
Thank you.
Hi, this is Ed Manuki. I had a quick question for you. So, and I might have missed this. So is this sort of a population surveillance study, or is this individualized reports that are going to go back to the students?
So it is a population-based study in the sense that we'll be sampling from a well-defined population, and sampling.
Will individual students be receiving the results of their individual samples?
Yeah, so that's a really good question. So, you know, Dr. Masaudi and I are involved in another surveillance study among healthcare workers. So I know, so we've been kind of going back and forth, you know, since the testing will be done in Dr. Masaudi's lab, which is not a CLIA certified lab. So there's some complications in terms of what can be reported to the participants. But I think our experience so far has shown that the participants, you know, really are seeking their individual information, and
Right.
that they're
So
aware.
a couple of suggestions. One of them, you might want to, you know, I think Sebastian Schubel and Phil Feldner and Sanghyuk Khan have worked out an arrangement with IRB approval that involves a data management board that has been at least empowered by IRB to potentially give the information out to the individual participants. The
Yeah.
other thing to be aware of there, however, is that the UCOP guidance that's coming out and has been present in draft form already has very specific language in the UCOP guidance about the delivery of individual results having to come from a CLIA laboratory. And so I actually, once I saw the draft guidance, I sent that immediately to Sebastian just to make sure that this was going to be compliant with the IRB ruling on this.
Yeah.
So at any rate, I think those are, issues in the past. It really has been sort of anathema because there just isn't the possibility of having sort of a level of regulatory compliance and oversight of the research environment at the same level that's sort of required by federal and state requirements for individual reporting. So just something to be aware of. You might get guidance from Sebastian and Phil and Sanghyuk about how that's working with IRB. But just so you know, that UCOP guidance on COVID testing had very, very specific language in it about the requirement that individual results had to come from a CLIA laboratory.
Yeah. Yeah, no, thank you.
Ed, I'm sorry, this is a really important point, obviously. I didn't understand where the UCOP guidance is saying, from where the UCOP guidance has to come. Are you saying a physician or a CLIA certified has to be retested?
A report in the language. It was buried in the many page guidance, but it basically says a report that gets delivered back to an individual, whether it's research or not, has to be performed in a CLIA laboratory in order for that individual to receive the result.
So then, just to be as clear as we can be, the process might be, it would go from a research study to a CLIA lab as an individual identified, and then pushed out to the.
So that's the other compliance,
right.
And that's the way that we have sort of worked it out with Phil and his group, to some extent. Is that the idea is that if you do have an MD who is able to place an order on the research team and the patient consents to get the CLIA test, that can be done in a reflexive way if there's a positive result. But it wouldn't be done reflexively for everybody because that wouldn't make sense necessarily. But that would overwhelm the system.
Yeah, no, we've been in contact with Sebastian and Sanghyuk and them as well.
So I'm not sure how they're handling this misalignment with the UCOP guidance that's going to come out, and the UCOP guidance is not final, right? I mean, I don't know, Pramod, maybe you've received the final form of that. I've seen 2 drafts, but
I think it's going
at any rate.
It's going to the UC president and the chancellors. They are the ones to receive that guidance. So we have to wait for that to happen.
And then Ed, if the results, so, this is a reason why Sanghyuk and I were very adamant with our participants that we would only release aggregate summary data and not individual data. And we were very clear about this.
Right. And I know you and I have had discussions.
Yes. But we're now coming up against this thirst for knowing what my status is, right? So we were very clear with our participants, especially in our healthcare worker surveillance study, that we said we will send around a newsletter with aggregate data so you can see. It's not that exciting since basically 2 out of 300 people had antibodies. Like, we both know that this is very low. So anyway, we tried to say we'll send aggregate data, and we're just getting inundated with requests for getting an individual result out. And so, sure, we can get an MD to write an order for a CLIA lab, but then who's paying for that lab?
Well, so typically insurance is paying for it. If there's insurance is covering the test, either
So
antibody or
any MD can write this order, and the insurance will pay for it. it doesn't have, there doesn't need to be a compelling reason for it.
If the physician orders it, that
Okay.
suggests there's a compelling enough reason for it.
Okay.
Right.
And
And
that could,
I do think that it may be students. So, you know, for the healthcare workers, of course, there's a lot of anxiety in terms of, you know, potential exposure to patients and in the hospital setting. So with the students, I'm not sure, I'm sure that the student participants would also be very curious to get their results, but I'm not sure it will be as Ilham mentioned, the thirst for it might not be as intense. So I think it's, but no, thanks for raising that point, Ed. And I think, we have a DSMB set up for our healthcare worker study. And we in fact suggested that to Sebastian as well. So, we're kind of looking at multiple ways that we can handle this. And I think our experience with the healthcare workers will, you know, it's going to be very helpful in terms of, you know, devising the language that we might use. And I actually was not aware about the UCOP guidance, so I'll definitely look into that as well.